تمام، احنا كده بقينا لايف حالا.
Okay. Dr. Mahmoud Ezzat, DSD Instructor. I like to call you DSD Ambassador in Egypt, Middle East Manager DSD, علامة. How and when DSD بقى trend في مصر امتى أو دخل مصر امتى وازاي؟
طيب, let me just first I'd like to thank SPC Training Academy for giving me this opportunity to be on the platform and to share with you this lecture live. We have given a lot of courses together. We've been giving courses together for the past 2.5 years. Mm-hmm. And it's one of my greatest honors to be also live with SPC Academy and with all their followers. I'd like to thank Dr. Sarah Taban and Ahmed for being with us today and for hosting this watch party. And the question was, if I remember well, how did DSD come into Egypt, or how did it become popular or known in Egypt? It started in 2015. In 2015, I was introduced to digital smile design. I took a course with the founder of Digital Smile Design, Christine Kochman and Livio Yoshinaga. They were doing their world tour at that time, and it was in Abu Dhabi. And one of the reasons that made me actually, that made me go take the course was that I had difficulties with my aesthetic cases. I would work very hard with the cases. I would try to get perfection and very nice results, but at the end, I was never able to get these results. I had problems with my lab. I had problems with communicating. I had problems with the lab having a certain perspective about the case itself, and then me also having a different perspective for us to meet together our minds and be able to get to the perfect case was very difficult. The day of cementation was usually a nightmare because the ceramics would look beautiful on the models, but when you put them in the patient's mouth, they would look totally off, as if they weren't this patient's veneers, to the extent that sometimes if we had 2 cases that we were going to cement at the same day and their names weren't written on the models, we would actually sometimes think that maybe these veneers are for the next patient. That was my main problem. So when I started to search a little more on social media, and I found the DSD courses, and I started to understand that this was a protocol that would help you to efficiently communicate with your lab, that would help you to treatment plan your cases and do diagnostics for the cases very well. It was a tool that you could use the face to design your patient's teeth so that it would be customized for that patient, because the teeth are part of the lips and cheeks. So all of these things got me more interested. I went and attended the course. I was determined to go through the steps of digital smile design, because there's an accreditation process. When you attend a course for the first time, or an official course, you become a DSD member. And then when you finish 3 documented cases from the beginning to the end with their protocol, then you become a DSD master. And then when you host a full DSD course by the founders in your country, you can become a DSD instructor. So I went to the course determined to take both steps, or the first 2 steps at one time, become a member because I'm going to attend the course this way or that way, and also admit my cases at the same time. So I kept searching a lot. I kept trying on a lot of cases, clinical cases. I would spend nights trying to do the smile design. At that time, we used to do it on PowerPoint and Keynote. I was getting there, yes, but there were a lot of problems that I had, and I was stuck. And I was determined to do that so that when I go to the course, I can benefit the most and really understand the things that are missing. So when I attended the course, I met Christian and Livio Yoshinaga at that time. I showed them my cases. They were very happy with them. And after I attended the course, after about 1 month, I, of course, adjusted the things that I learned from the course. And I admitted my 3 cases, and they were accepted. And then I became a DSD master straight away. And then I was determined to bring the knowledge of digital smile design to Egypt. I wanted people to understand more this concept and how valuable it is and how they could really use this in their clinics. So the course was in Jan. In the next October, we had arranged already for the DSD World Tour that was partly in Egypt. And we had a very successful course. At that time, it was a 3-day course, and we had more than 100 participants that attended. And that's when I became a DSD instructor. And from then on, it just went on. I started educating a lot of dental colleagues about digital smile design, not only in Egypt. I then did also a Middle East tour with Christian Coachman. He would give 1 day of the course, and I would give the second day. And we did 2 Middle East tours, 10 consecutive days after each other. And mainly they were in Morocco, in Egypt, in Saudi Arabia, in Jordan, and there was one more country. I think it was Dubai. Yes, we did that twice. That was in 2016, and then things just opened up, and I started to give the DSD courses worldwide, and mainly also this past year and a half. We started boosting this even more in Egypt. Not only the didactic part or the lectures and the workshop and the live demonstration of the patient, we even started doing this with the SPC Training Academy, that we started working on live cases in front of the participants. We would finish in one course about 6 to 7 veneer cases from the beginning to the end, showing the planning and step by step how we use the DSD protocol. And the participants would even prep the cases on their own. So it was like a one-to-one hands-on training on patients. And this is the way we've been implementing it for some time. And I think it's going very successfully. And a lot of people are benefiting from what we're giving them.
Thank you a lot, Dr. Mahmoud. Such an honorable story. That's amazing. وبأمانة يعني your presence is such an upgrade for SPC. You added a lot to us and you hired the standards.
Thank you very much. Thank you, Sarah. Okay, so we have one quick question before we start, because we have a lot of people joining. We were just discussing this before we went live. Would you like the lecture to be in English, purely English, or a mix between English and Arabic? So if we have anyone that does not understand Arabic at all, please comment. Because if so, then we will have the lecture totally in English. So if anyone has a problem with having the lecture in English and Arabic, please comment on our live posts. And if so, we will give it in pure English. So Sarah, if you get any comments, please let me know, because what I'm watching now is my timeline. So if you have any comments, let me know, please.
Okay.
Okay, so
shall we start talking about direct composites guided by DSD?
Yes.
And what are the difference between, the old-fashioned way, direct composites, or even the ones done indirectly, and between the others done guided by DSD?
Yes, sure. I'm going to start sharing my screen, if that's okay. Yeah. Okay.
Go.
So their screen share. And did the lecture go? There's the lecture. And okay. So let's start. As we said, let me introduce myself first. My name is Mahmoud Ezzat. I am a board member of Digital Dentistry Society, also the president of Digital Dentistry Society Arab Union. And as you understood, I'm also a certified DSD instructor. So before I start, I'd like to give you an overview why I actually thought of this concept. And Sarah helped me a lot with the introduction just now. that it's not the traditional way of building composites or anterior composites for your patients. Since I started understanding digital smile design and doing digital wax-ups for my patients, and teaching this to a lot of colleagues in dentistry, I would always be asked a question at the end of the course, of our 3-day course. Are we able to do this with direct composites? And the problem was that the answer was always no. And I would always ask them, so why do you really want to do this with direct composites? We usually do this with veneers or with indirect restorations. It doesn't have to only be veneers, it could be veneers and crowns also. And the answer would be that not all patients actually can pay for indirect restorations. That's number one issue. And the number two issue also is a lot of dentists would have liked the treatment options or the protocol to be more conservative. And this is an advantage that we have when we do direct composite veneers. So that got me really interested in the concept, although I'm not a person that really likes actually anterior composites, and I'll make you understand why. But I started to look for different ways of trying to implement this with patients, because as we understood that not a lot of patients can pay for indirect restorations, and also that it is a more conservative option. Of course, there are disadvantages of direct anterior composite veneers, that their longevity is not as good as indirect restorations. But of course, any treatment option has its advantages and disadvantages. So the whole point of the concept was I wanted to find a way to be able to do this guided in my patient's mouth, because one of the main things, or one of the main advantages of digital dentistry or implementing a digital protocol with your patients is predictability. So one of the main advantages of digital smile design is that you design the patient's smile according to the patient's face, and you do a digital wax-up. And using this digital wax-up, it is a baseline for you, and you show this to your patient. And after you show this to the patient, you can give your patient, or tell your patient, this is what you're going to get at the end, given that you do this with CAD/CAM or milling machines, that you can actually mill your restorations or your indirect restorations that look exactly like the mock-up. So this is predictability to your patients. So I wanted to do the same with the direct composites. When I started to try to do this, actually, and I used to do at that time a lot of freehand cases of direct composite veneers, it would take a very long time. That's number one. It would take hours if you're going to do it in one visit, and it would actually take usually several visits to be able to finish a full arch for your patient and to adjust this aesthetically. And you would have to do a tooth or two and then look back to the patient's face again and see if it looks good or not, and then readjust. There would be a lot of readjustments that you had to do. That was number one. And number two, also, you needed a lot of hand skill to be able to adjust the shapes of the anterior teeth with the composites, the texture, the surface textures, that it looks more natural. There's a lot of it's a technique sensitive, let's say, procedure, so that any general dentist has to be actually an expert in or at, so that he can give the best results for his patient. So the main objective of the protocol was to give the opportunity for any general dentist to be able to give beautiful looking anterior composite veneers for a patient that would look perfect on that patient's face, and at the same time have the beautiful texture and the shapes and the line angles guided into the patient's mouth, without having actually the hand expertise or the hand skills to be able to do this in less number of visits and less time, in a predictable manner and a repeatable manner, so that you can do this every single time on any patient that you choose. Okay, so that was the whole point of the protocol. So if anyone has seen the past 4 live lectures that I had given this week, These are the types of cases that we can implement digital dentistry on. We can implement it on an additive restorative, subtractive restorative, meaning a simple or a complex veneer case, an ortho case. We can also use this for crown lengthening cases, and we gave a lecture about digital treatment planning of gummy smile cases, on implant restorative cases and fully edentulous, and we also gave a lecture about digital treatment planning of implant prosthetics, a new protocol that I'm using with cases that need an increase in vertical dimension of occlusion, and how we can take the full advantage of digital dentistry in cases that need, where you need to attain centric relation and increase vertical dimension, in orthognathic cases, in digital direct composite technique, which is the technique we're going to show today, and facial restorative, where you can use also Botox and fillers injections guided. So yes, the future is now. You can use this protocol, you can use digital dentistry to guide your direct anterior composites, and that's what we're going to see in the coming slides. Now, I'm going to show you or explain to you first the workflow that we use, or the digital workflow that we use. And usually the workflow is the way or the sequence that we use for the case, or any digital case that we have, so that we know which step that we're in and which step we need to go to. So we usually have, for any case that we plan digitally, 5 main steps. We start first with the design, where we use the patient's face, as we said before, and this is the concept of digital smile design. We take photos of the patient's face, and using the patient's face, we start to design where the teeth should be, or how the teeth should look according to the patient's face, so that it is a customized smile for that patient, and it looks perfect on the patient, at the end, and you don't have to go through the dilemma that I used to go through, and a lot of dentists still go through, if they don't use this concept, which is a guess game by you and the lab, and hoping that it would look good on the patient at the end, on the day of cementation. But unfortunately, on that day, you've already finalized with the lab, and the lab has already fabricated the restorations for you. So what happens is, you either have to persuade the patient or convince the patient that this is the best result that he could get, and just cement them for him, and he leaves not so happy, or you would have to send these back to your lab technician to readjust and adjust and adjust again and again. Either send the patient to the lab and try to readjust, or you go with the restorations to the lab and try to communicate with the lab, and you would go back and forth. So to prevent that, we will use a facially guided vision. We design our teeth according to the patient's face, and the same also is going to be used for the digital direct composite technique. Of course, there's no lab technician part in here with restorations, but the lab will come in with designing or doing the digital wax up for you, as we'll see in the coming steps. So after we design according to the patient's face, we then have to present first, and this is where we motivate our patients. We make our patients value more the treatment that we're going to give them. And put in mind, this is a very simple protocol, but it's very, very important that the patient has the right to see the end result before you start, before you touch his or her teeth, before you reduce their teeth, before they put them in the situation that they pay for the treatment, and they are put in the situation that you have to cement, or you have to go for the finals or the day of the final restorations. The patient has all the right to see the end result before they start. You can't make your patient trust that you will be able to give them the final result with just words and saying how good you are and how skilled you are for years of doing this. This is not possible anymore. So this is a motivation phase where we show our patients the results beforehand, before we start doing anything, with a simple mock-up strategy using the smile design protocol also, and we'll see how we're going to go through that. And then after we show our patients, this is when we start showing our patients and discussing with our patients the treatment plan. Not only our patients, we discuss this with the rest of our team. If we have an interdisciplinary workflow or a lot of dentists working on the case, and we usually see a lot of problems with that. When you have a lot of dentists working on the same case, you usually can't find where you are anymore, and you have to let's say readjust the treatment plan because the orthodontist, let's say, did not move the teeth enough, or the prosthodontist did not reduce enough. So how we can control each other as a team, how we can communicate and control the lab, and how we can also communicate with our patients, because patients that come in for dental treatment are usually patients that are anxiety patients. They do not like coming to the dentist. We've been said that more than 100 times by several patients that come in, that they don't like us, that they hate us actually. So you're getting you have to transform your patient from hating you to liking you when he comes into the clinic, to trusting you to pay for any treatment that you're going to give him. So this is that time when we start showing our patients the full treatment plan in a digital format so that they can understand what's going to be done for them, and then only they don't mind to pay whatever sum of money that you ask them for, and they really get into the phase that they trust you. And then later on, we'll show you how we produce guides, or we manufacture guides, because using a digital protocol, we want everything to be guided in the patient's mouth, meaning that we will spend a lot of time planning, 80% of our time planning on our patients, on our laptops or on our computers or on our softwares, and then we fabricate for the dentist or for ourselves guides that help us to do the execution or the clinical work in the patient's mouth without taking too much time, because we had spent most of the time during the thinking process and the treatment planning process. And then at the end, always, we need to have quality control, where we use the smile design process itself as a baseline, something we can go back to make sure that the results that we got are the results that we showed the patient in the beginning and according to our treatment plan from the beginning. And this is what we had promised the patient. So I'm going to show you how we're going to go through this workflow step by step. We're going to start with the design phase first. And to start to design, this is actually the main things that we need from any dentists from the beginning. We need a frontal smile photo taking for the patient, and this is a very simple photo that you can take. But please, we always ask the dentist to take this with a DSLR camera and not with your phones, so that we do not get any distortion. And it's a very simple protocol. You need the patient to be looking straight ahead, eyes open, full smile, both ears equal on both sides while taking this photo. The patient's head cannot be slanted to downwards or upwards, because then you would have a reverse curve in your smile curve, or a change in the smile curve. So you want the patient looking straight ahead, eyes open, both ears equal on both sides. If she has long hair, let her have her hair behind her ears. If she is veiled, let her tie the veil very tight so that you can see that the head is equal on both sides. And also what you need with that is a casual video, because you are asking the patient here on the photo to give you a full smile. And the smile that the patient will give you is never the full extent of their smile. As you can see in the photo here, I asked her to smile. Look at the extent of her smile here. Look at the exposure of the gums here. And look at the amount of exposure on the video that I got here. So with the frontal smile photo, we also take a casual video. So casual video meaning that you run your camera and you start talking with your patient casually. You do not ask your patient to smile, because if you ask your patient to smile, you will get the same effect as the photo. You say something funny and your patient will start giving you a casual, full extent smile, as you can see here. And this snapshot from the video is used as a reference so that you would know the full extent of the smile. So we cannot only depend on the photo, we always need also the video as a reference. And the third thing that we need are intraoral scans, upper and lower in occlusion, or of course, if you do not have an intraoral scanner, you just take a simple impression, but a full extension impression with additional silicone using putty and light, so that we have accuracy with the impression itself. And all the lab will do then is pour them into stone models, and they will scan them using their lab scanners, and they will have your patient's teeth in digital format. So again, to start this protocol, to be able to do the smile design, we need to take a facial frontal photo, and it has to involve the patient's face, because we're going to use the face as a reference for the design. You also need a casual video, and you need impressions or scans. This is your starting point, and from then we will start to show you how we will do the smile design process. Now, the smile design process involves 2 steps. It involves a 2D step and a 3D step. The 2D step, it's recommended to be done by the dentist, and this is what we teach our dentists in, or our colleagues in our courses, how to do the 2D smile design, and we also show them how we do the digital wax up. But the 2D smile design should be done by the dentist, because he's the one who meets the patient. He knows what the patient wants. He knows the patient's complaints, and he is more familiar with the case than the lab, of course. The lab can provide the 2D smile design for you, but we still recommend the dentists to do this on their own. So we're going to use this photo that we took of the patient, the frontal smile photo, to do the 2D smile design. And as we said, the whole point of the DSD process is using the face as a reference to design the patient's teeth. Now, for you to understand this protocol more, think of the fully edentulous cases that you had treated in university, or after you had finished your college degree. What we would do in the occlusion block phase, where the patient, after you take the primary, the secondary impression, and you put the occlusion block in the patient's mouth. What we used to do is we used to carve lines in the occlusion block, and these lines were according to the face, according to the patient's face. We would look for the midline, the glabella, filter, mention, and then we would carve a straight vertical line in the occlusion block showing where the facial midline is. And then we would look where the inner canthus of the eyes are, and then we would carve another line for the canine eminence. And then we would adjust the occlusion block according to the patient's lower lip while the patient is smiling. We'd also ask the patient to say MM sound so that he would be at rest and see the amount of exposure at rest and know if, or decide whether we need to make the teeth longer or shorter. All the changes and all the carvings that we used to do in the occlusion block was information that we used to give the lab technician. We would send that occlusion block at the end, and then that carved line in the midline, that would show the lab technician where the dental midline is, and he would then set the 2 centrals on the occlusion block. The adjustments, any adjustments you would do in the occlusion block would give or translate as a meaning to the lab technician where to set the teeth. It's the same exactly what we're going to do here using the patient's photo. Why? Because when the patient has teeth, you cannot draw or carve lines on the patient's teeth according to the facial landmarks. So the easiest way is to take a photo of the patient while the patient is smiling, put this on your laptop, and then start drawing lines. And these lines will be superimposed on the patient's face, and we will send the photo with the lines on it to the lab technician, and then your lab technician would do your digital wax up according to the lines. So you have then used the face as a guide for your smile design or to design your patient's teeth. So step by step how we do this. This is, of course, not our main subject of the day, but so that people can understand the protocol that we have used for the digital direct composite technique, you need to understand first, whoever has not attended a course or an online lecture with us. So step number 1 is we bring in our horizontal line. And this is something that's very important, because put yourself in the place of your lab technician, let's say, and you have sent him a model and you asked him to do a wax up for you. Okay, and let's say that the patient has a cant, meaning that the premolars on one side are longer than the other. If you look at any lab technician at that time, usually what he does the first 5 minutes is he starts to try to orient the model in horizontal axis. He keeps turning it around till he has adjusted horizontal, because if he holds the model in this direction, let's say, then your curves or your smile curve will be totally different. So what if this patient has one side already, he has one side that's over erupted than the other? Then he will keep adjusting the model until he adjusts his horizontal according to the teeth. But we cannot adjust our horizontal of the model according to the teeth. We can adjust the horizontal according to the facial references. So this is what we're doing now. We're using again the face, and we're using references on the face so that we can adjust our patient's teeth accordingly. So when we bring in 2 horizontal lines, we look at our first 2 facial references, which is the interpupillary line, the line between both pupils, and also the intercommissure line, while the patient is smiling, the line between both commissures. And if you look at the photo very well, you can see that these 2 horizontal lines are not in or equal to the intercommissures or the pupils. So the photo needs to be rotated just a little. So accordingly, we rotate the photo, as you can see. I'll go back 1 slide. We bring in both lines, 2 horizontal lines, And now I'm going to rotate the photo according to these two horizontal lines. Now, this rotation that I have done to the photo will be reflected onto the model when I bring in the model in the lab steps that you see, and you will understand how we have oriented the model automatically according to the patient's face. So that's always step number one. Step number two is when we bring in a vertical line, and now we are doing the same steps that we used to do with the complete denture patient, where we are looking at the facial references, which are the glabella, philtrum, and chin. And here we are trying to detect where the facial midline is. So now that we have drawn this vertical line according to the glabella, the philtrum, and the chin, we now should relate this facial midline to our dental midline and start to decide, will I use my dental midline or will I use my facial midline? And this is when we start to look at the literature that shows us the aesthetic principles or smile design principles, where we go back to the literature and start to decide whether to use the facial midline or use the dental. And it's a simple protocol. If the difference between the facial midline or the shift between the facial midline and the dental midline is less than 4 millimeters, we always use the dental midline, because this is something that no one can detect or see that you have a defect in your midline or not. Okay, so that is our vertical, or step number two. As I said, this is actually not our true topic of the day, but we need you to understand this well so that you can understand the coming steps. Usually this is discussed in half a day of our courses, so that you can understand the concept, the value of the concept, why you really need the face there, and we show you the aesthetic principles and make you understand the facial references more and these lines, what they mean. So step number three is where I bring in the smile curve, these red dotted lines. And what the smile curve shows, it shows the incisal edges of my teeth, where they should be. Now, when we're designing here, we're designing again according to the face, and we do not put in mind where the patient's teeth already are. Okay, so remember when the complete denture case, when we used to ask the patient to say M sounds, and the point of the M sounds was to have the patient at rest, his lips at rest. And then we would look at the amount of exposure or the amount of the occlusion block that you could see through the patient's lips when they're at rest. And according to age and sex, if the patient was old male, let's say, for instance, we would want the occlusion block to show about 2 millimeters from the lips at rest. This is the same that we do here. We took a casual video, and during the casual video, there's a time where the patient is at rest, and you can detect the amount of exposure while the patient is at rest, and then decide where the smile curve should be. Let's say that this patient, she's a young girl, she should be showing about 3 to 4 millimeters average at rest. So accordingly, and that's what she showed us in the video, accordingly, I will not need to make her teeth either longer or shorter, because this is the amount of exposure that is the normal exposure for her age and her sex. So accordingly, I will then place my smile curve at the same position of her incisal edges already, because I do not need to make her teeth longer or shorter, because she's already showing the amount of exposure that's correct for her age and sex. So that's the first thing that I put in mind with the smile curve. If I bring the smile curve to a higher level, means I'm going to make her teeth shorter. If I bring it to a lower level, means I'm going to make her teeth longer. So I hope that's understood. It shows, the smile curve shows the new incisal edges of the centrals, laterals, canines, and premolars, and even the mesial cusp of the sixes if she shows it while smiling. So what about the shape of the curve? Why is it curved in that way? Why is it not a straight line? The smile curve should take the shape of the lower lip while the patient is smiling. And this is another reference. And this is a systematic literature review showing that the smile line is a valid parameter for the aesthetic patient's aesthetic evaluation, that this smile curve should mimic or should take the shape of the lower lip while the patient is smiling as much as possible, of course, because in front of any aesthetic decision that you take, there is also a biological and functional circumstance. And this is also part of what we show you in the course, how to take the aesthetic decision without or weighing between the aesthetics and the biology and the functional issues with the patient, because these are our main three triads in dentistry while treatment planning. So again, we started with the horizontal line, we then started with the vertical midline, and then we adjusted the smile curve according to the shape of the lower lip and the amount of exposure that the patient shows while at rest, depending on age and sex. Then in step number 5, we then show the interdental ruler or start deciding the widths of the teeth. And as you can see, in this case, this patient has multiple spacing between the teeth. So should I give the spaces between the centrals and laterals to the centrals only, or should I give them equally to the central or lateral, or should I give it to the laterals only, or should I give it in different percentages between the centrals and laterals? This is a decision I need to take. So here we start to adjust the widths of the teeth. And again, we use a facial reference where we look at the inner canthus of the eyes, just like the complete denture patient. And we used to draw where the canine eminence is. We draw two lines at the inner canthus of the eyes and in relation of the width of the nose. And we see this, and we draw this line in relation also to the patient's canine eminence that is there already. And now if you look at these two red lines, we already now have the arch perimeter, which is the total width of all the centrals, laterals, and canines. So all I need to do is now divide this space that I have between the inner canthus of the eyes and give a proportional width for my central, lateral, and canine. And we have proportions for this. The most common proportion that you're all familiar with is the golden proportion. But what we use since 2007, because there are a lot of studies regarding this concept, we use a concept that's called the recurring aesthetic dental proportion, or proportion called red proportion, which means that if, let's say, the width of the central is 100%, then the width of the lateral will be 70% of the central, and the width of the visible part of the canine would be 50% of the central. So giving as an example, let's say that the width of the central is 10, then the width of the lateral will be 7, and the width of the canine will be 5. And please put in mind that the canine is divided into two parts, a visible and an invisible part. We only mean the visible part until till the part of the canine eminence. So here we have brought in our interdental ruler, and this is a very easy step that we do here because this is already on our 2D softwares that we use. We bring in a ruler that is already adjusted and proportionate to the red proportion. You just need to adjust it on the two canine eminence lines or inner canthus of the eyes lines and to the midline, and it will give you your proportion automatically. And you can see here that it started to divide the spaces between the teeth, and we'll see a close-up photo of this so that we can see the full treatment plan for this case. Then step number 6, now I have, you can see here the interdental ruler, these yellow lines. It shows the width of each tooth. It shows the new width of the central. It shows the new width of the lateral. It shows the new width of the canine. And you can see here that we have given the space mostly for the central on this side. And we have divided the space just a little equally here between the central and the lateral. Why? Because she has a shift to this side, as you can see. You can also see that she has a cant in the midline, meaning that the midline is not straight. It is a little crooked, and this is something you would not see unless you placed lines here. So this is something that we're going to put in mind while designing the new set of teeth. The width of the lateral here is going to be just a little wider mesial. The width of the lateral here is good enough, but this line angle needs to come a little more mesial. The canine eminence here will be shifted a little distally, and the canine eminence here is just perfect. And what you can see from the smile curve here is that this central, the length of this central is more than perfect, but this central is a little shorter, so it needs to be come a little longer. The laterals are okay. The canine here is a little shorter, the left canine. The premolars are in a good position. This right second premolar is just a little longer. So this smile curve is now showing me all the adjustments that I need to do in my patient's mouth. It's showing me my starting point and my end point. My starting point is where the teeth are now. My end point is the lines that I have drawn, and all these lines represent the facial analysis that I already did on my patient's face. Now, in these steps, I do not need the face anymore, and I can start to take other decisions. I have now the width of each tooth. I have the width of the central, lateral, and canine. I now want to decide how long this tooth is going to be, or the length of the central. So we have also, according to aesthetic analysis and principles, this was done by Frediani in 2004. We go back to the literature once more, and we'll find that we have a ratio between height and width, meaning that if we have a certain width, then we should have a certain height for the central. So the research or the publication showed that the ideal height to width ratio of the central is 80%. What does 80% mean? It means that if the length of the central is 10, then the width should be 8, but and this would be the ideal situation, but you cannot use this situation every time for every patient. So they gave us a range from 75 to 85%, meaning that if the length of the height of the central was 10, then the width would be 7.5. And also if the height was 10, then the width would be 8.5. We also have a limit from 70 to 90%, but we do not recommend the use of these percentages unless you are going with mostly orthodontic cases. So we usually stick to the 75 to 85. So now the next step is I'm going to bring in always my ideal first. I'm going to bring in a box, and this box represents 80%, meaning that this box, its length is 100% and its width is 80% to the height of the box. No matter how big or small I make this box, the proportion stays constant, 100 to 80%, meaning it's an 80% box. So when I bring in this box, I already know the width of my central, or the new width of the central. I adjust this box to the midline. I adjust it to my new smile curve. I adjust it also to the distal of the central. Automatically, it will give me the top or the height of my central. And as you can see here, because we made this central just a little longer incisally, then the correct 80% proportion for the central will be just at the patient's already existing gingival margin. So now I knew the new length of my central according to the new width that I had decided according to the Interdental Ruler, which was taken from the width of the nose and the intercanthus of the eyes. And from now, or from this information or from this box, I now know where my new gingival levels should be. And this is what we call the gingival curve. The gingival curve is a curve that looks nearly the same as the smile curve. The smile curve shows where the new incisal edges of the teeth should be. The gingival curve shows where the new gingival margins of my teeth should be. So I can see from this gingival curve that my central is at the correct level. This lateral should be just a little shorter, usually 1.5. The canine is good in position. The 4 and 5 here are no problem. But when you look at the right side, now look at this central. It's just a little short than the gingival curve, meaning that we're going to need a little gingivectomies here. The lateral also is in the correct ideal position, but we will need to equalize this lateral to this, either by a gingivectomy in this at this lateral, making it longer, or by, let's say, a soft tissue surgery at the left lateral to make it just a little shorter gingival. The canine here is at the correct position, and the premolars, we have no problems. So what you're doing now is, and you can actually start to understand this more, because we have a cant on the right side, and this is evident that this whole right side is just a little more over erupted than the other side. So that's why you have it at the correct length incisally at the smile curve, but it's shorter at the gingival, and that's why you have this, the left side, the gingival is correct, but the incisal is too short. So now you're starting to understand where the defects, or what are the defects that the patient has in his or her smile, so that you can adjust this later on. And this reflects also to why we have a cant, because this side has over erupted just crooked just a little, and that's why we also have a cant at the midline. The last step is where we bring in a papilla curve, which shows where the papilla tips of the teeth should be. As you can see here, this is the papilla tip between both centrals that already exists for the patient, and these are her papilla tips that already exist. This papilla curve shows where the contact points of my teeth should be, because the contact point of your restoration or of your teeth usually govern where the tip of the papillas are. So it reflects to my lab technician where the contact points for the wax up is, and it also reflects for me in my design if my papillas are sufficient or not, or do I have deficiency in soft tissue or in the papillas here, and do I need to regenerate this or not. And as you can see here, the papillas here are in the correct position. So you're going to ask me the next question: how do I decide where the papilla curve should be? Because the gingival curve was decided according to the 80% box, which was the height to width ratio. The smile curve we decided according to the amount of exposure at rest. But the papilla curve, we decide that it should be, and this is also a study that was done by Chu in 2009, the papilla curve should be in the position of 30% of the whole length of the central, the new length of the central, not the old. So if I measure the distance from my gingival curve to my smile curve, let's say it's 10 millimeters, then the papilla curve position should be at 30% of that, which is 3 millimeters of the length of the central, and it's usually 30 to 50% of the length of the central. So these are the 8 steps that we did for our smile design. If we go back once more very quickly to top this up, we started with the horizontal line with the facial reference of the pupils and the commissures while the patient is smiling. We then rotated the face according to that horizontal line. We then brought in a vertical line which shows according to the glabella, philtrum, and chin, which shows the facial midline. And then we start to relate this to the dental midline. And if we have a shift that is less than 4 millimeters, we use the dental midline and not the facial. And then the third step was, the third and fourth step involved the smile curve shape, which should take the shape of the lower lip while the patient is smiling, and the smile curve position, which is decided upon according to the age and sex of the patient and amount of exposure at rest. And then we brought in the Interdental Ruler, which shows the width of each tooth proportionate to each other according to the red proportion and according to the position of the canine eminence according to the inner canthus of the eye. And then we would then bring in the 80% box, because now we have the width of the teeth. We also need the height or the length of the new central, and the rest of the teeth follow. So this 80% box is only used for the centrals. So when we bought in the 80% box, we found that this gingival margin is correct. This is the new level of my gingival margin. Accordingly, this is the position of my gingival curve. And another question that I'm usually asked, what about the shape of the gingival curve? We try as much as possible to give the shape of the gingival curve the same shape of the upper lip while the patient is smiling, so that also you give a customized smile for that patient. What is acceptable is a straight line to any curve, but you cannot have a reverse curve with the gingival curve. This is not acceptable. And then last but not least, which is very important when you have missing teeth or with ortho cases where we have intruded or extruded teeth, you need to decide where the papilla curve is, which is 30 to 50% of the length of the central. So from these steps of the smile design, and this is the 2D smile design again, and this is what is asked of any dentist to do for any patient that comes in. This is a treatment plan, platform, or protocol that I use for every patient that involves any anterior restorations, not only for veneers, for composites, for implants, for ortho, for orthodontic, for perio cases, whatever you can imagine. So what we have been doing is we're taking smile design decisions through facial dynamic analysis, because these lines were taken or placed according to facial references. So we're using facial dynamic analysis because we use a video as a reference for giving our smile design decisions. And we are starting to understand or getting a 3D understanding through the 2D images, because we started to understand why we had a cant and why one side was over erupted more than the other. And we started to understand the widths, the new widths of the tooth according to her face. And we are also helping our eyes to see more so we can make better smile design decisions. As you saw, where our eyes are used to comparing things to each other. So without those lines, we would never be able to compare our dental midline to the facial midline. I know that we had a cant. When you have lines there, you can see even the most minute defects that this patient has, so that you can give that patient that perfect smile that you all wish to, or us as dentists are perfectionists actually in our work, and we love, we always strive to give our patients perfect results. Even if our patients are happy with the results, sometimes we are not, and we're not satisfied with the results that we give, because we are always looking for perfection. So this is where actually one of the most benefits of the smile design process is predictability, and to give your patient perfect results with even the least problems. Okay, so the next step is, after you have done this smile design and you have a photo of your patient with the lines on it, you take a snapshot of that photo and you send it to your lab technician with your models and your scans. So this is the photo that you're going to send your lab technician, a face with the lines on it. That's all you need to do as a dentist. Then upcoming steps are what the labs need to do, and there are only certain labs that are actually trained how to do this process, and they are certified by Digital Smile Design. They go through a process of accreditation also, where they have to become members and then DSD masters, and then they become certified DSD labs. And we have already a lab that is certified through Digital Smile Design in Egypt that supplies the Middle East, and this is the lab that we use throughout our process. So what I send my lab is a photo with the lines on it, and I also send them an intraoral scan or an impression of my patient's upper and lower arch in occlusion. Then what do? What we want them to benefit from all these lines that we have drawn, because this is our plan, exactly like the complete denture patient. When you send the occlusion block with all the curves on it, then the lab technician knows where to place the teeth exactly. So how are we going to do this in our digital format. So simply, the lab technician brings in the photo with the lines on it, and then he registers the model to it. Means that on the software, he brings the model and places the model on the patient's face exactly in the same position in space. How can he do that? He has common points. He can see the centrals, or he can see all the anterior teeth in the photo, and he can see those same anteriors on the model. So he gives reference points to his software, telling him that this is the incisal edge of this central, this is the incisal edge of this central, this is the canine tip, this is the canine tip here. So please put them on top of each other. And this is exactly what we see on the slide. Yes, Sa.
We have a question here. Someone asked you if you could repeat how did we detect the width and height of the incisors. So
okay, sure. Let me finish this step and I'll go back to that straight away. Okay. So after we have done our 2D, as we said again, the lab technician brings in the photo with the lines on it. They bring in the model also, and as you can see, the model is exactly in the same place as the patient's photo. Now, so simply, just imagine this photo here with the model there, and I erase the photo. What will remain? The model with the lines on it, and these lines will show my lab technician exactly where to do the wax up. This is exactly what my lab technician uses. Now they have the model with the lines on it. Do they need the face anymore? No, because these lines reflect exactly the facial analysis that I did. And from there, the next step is the lab technician brings in tooth shapes. He chooses from his library, which are natural tooth libraries that we use. He brings in these tooth shapes so that they accommodate to these lines that I have done. Now, if you think of it, we call it a smile frame, meaning that we have a frame for every single tooth. The central, there's a box for it, meaning the mesial, it shows where the mesial should be, where the incisor should be, where the distal, and where the gingival should be. So we're giving a frame for each and every single tooth. All the lab technician needs to do is to set the teeth according to these boxes that we have given for each tooth. It's exactly like the complete denture patient. You send him the occlusion block with all these curves and lines showing him where the gingival, incisal, and the mesial and distal of each tooth should be. He just sets the teeth there. So now you are in complete control as a dentist. Your lab technician knows exactly what you have asked him to do. And the smile design was done according to your patient's face. And this is the meeting point between you, your lab technician, and your patient. This is when you understand what the patient needs from the patient's face, and you will show this to the patient later on. And this is where your lab technician understands very well what you want of him to do exactly. And this is where you understand what your patient needs. And this is where you all three of you meet. So to go back to the question that we had from one of the attendees, how did we decide the length of the central, correct? Sarah? So you were asking how do we decide the length or the height of the central. Now from the Interdental Ruler, we already know the width, the new width of the central. And we already have a ratio that is in the literature that and this ratio says, or the literature says, or the reference says that the ideal height to width ratio of the central is 80%. What does that mean? For an example, it means that if the width of the central is 8 millimeters, then the length of the central should be 10. So it's that easy. I already have the width. Now I'm going to bring in a box that represents this 80%, and I'm going to put it at my new width, and it will show me exactly where the length of the central or the total length of my central. It's that simple. Okay. So if you're doing this by measurement, you already know that if you're not doing the smile design process, so that it's easy, so that you can understand this more. I have measured the width of the central is 9 millimeters, let's say, for example. And I know that I have a height to width ratio in the literature that says that the ideal height to width ratio of the central is 80%. So the width is 9. How long should my central be? The central should be 11. It's just cross multiplication. It's mathematics. Okay. So instead of you doing the whole mathematical issue, we give you boxes that represent 80%, and we give you a box that represents the range that we have, which is 75 and 85%. And you already have the width. All you have to do is bring in the box, and then you will get the height. Another question that we were asked, what about the gingival curve? That's the next step. So this height to width ratio box showed me where the gingival curve should be, the level of my gingival margins. So accordingly, this is the new level of my gingival curve. And as we said, the shape of the gingival curve is taken by the shape of the upper lip while the patient is smiling. So I hope that we were able to answer that question. And we stopped at this slide where we, again, the lab technician imported in the photo with the lines on it, and then they registered or aligned. We call this registration in digital dentistry, registered the model to the face, and then we erase the face totally. We don't need it anymore. And these same lines that you had drawn on the patient's face are now on the lab technician's model, and now he can do a digital wax up for you. Now I'm always asked, can't we do this manually? Can we do the wax up manually and take measurements? Yes, you can. But will it be accurate 100%? No, it won't. That's why we always do this digitally. So one other advantage of doing this wax up digitally, I told you before that these are natural tooth shapes. Yes, they are actually. Now, and this is a concept that we all have to really understand or try to think through very clearly, and will help us in the direct composite cases. Now, when you send to your lab technician a wax up, let's say, to do for you, or a central or lateral, an anterior tooth to manufacture for you. After they manufacture the central or lateral, what did you do on the labial surface? They bring really thin burrs and stones, and they start to draw the surface texture or carve the surface texture on the tooth and adjust the line angles of the tooth. Now, just imagine, and these are studies that were done, that even the best lab technicians in the world, they had in their minds mostly 2 to 3 shapes maximum that they are usually comfortable with, and they do not change around a lot. So if you think of, you sent 10 models to your lab technician, he will give you mostly 2 shapes that are in his mind, because these are that he are most familiar with, and these are the shapes that he usually mostly likes, and he will start to adjust the surface texture and the line angles on these teeth with his own hands manually. But this is the anatomy of the tooth, is something that God has created, is something we have not understood till now. We see certain shapes with certain line angles, with certain texture that are mixed up together in certain areas that we really do not understand why, or the geometry of this and why it was done in that way. So the easiest way, instead of depending on your technician every time, depending on how tired he is, if he likes this case or not, if he had implemented a lot of effort on this case or not, would it look natural or not, then it's easier to use the natural shapes that God has created. So what did we do? So simply, if let's say I liked the 2 shapes that Sarah has with the surface texture that she has on her teeth. So simply I can scan her or take an impression and send this to my lab, and they will scan it for me. And on my software, I can cut out these teeth from the software and use them in my library to use them for any other patient. So what am I doing now? I'm using God's creation of natural texture and natural shapes and line angles for someone else, instead of doing it with my hand and trying to get this this perfect result that is very difficult to do with your own hands. So, and this is one of the main advantages of using a digital wax up with natural tooth shapes. And why are we looking for natural tooth shapes, and why are we doing this texture and this line angles? Because patients now are looking for natural smiles. And this is actually our job as dentists. Your job as a dentist is to give your patient back what your patient has lost. Your patient had a natural smile some time ago, and she or he lost some teeth with caries, with extractions, with whatever, with trauma, and they want back what they have lost. And this is actually what we are supposed to do. We are not supposed to give our patients unnatural smiles. We're supposed to give back our patients natural smiles. And it's more difficult as a dentist to give your patients natural smiles than just, as we say, chiclets, flat teeth that are all flat and one size incisally, or one length incisally and one length gingivally. This is not what our patients want, or this is not what our patients are asking for. Yes, patients are asking for brighter teeth. If you went and as a dentist to do veneers or composite veneers for your teeth, you will ask for a brighter shade. This is for sure. But what will make it look natural and bright at the same time are the natural shapes and the natural surface texture. So this is one advantage that we get from natural teeth. Okay. So from there, after we do design, I have one more question. Just to clarify something here, calibrating a ruler here has not needed because you calibrated the 3D. Yes, exactly. Dr. Rami, I do not need to calibrate. We do not calibrate the ruler anymore because we calibrate this to 3D. Yes, you understood that very well. So our first step in the workflow was to design. Now our second step is to motivate our patient, to show our patient what he or she is going to get before we start going for the treatment, and before we give our patient the treatment plan, before we discuss cost with our patient. So this is, of course, a learning curve and a process that we teach you, but I will show you quickly how the protocol is done using the smile design that you have done for your patient from the beginning. We then send this to the lab, and the lab has given you or designed your digital wax up. This digital wax up, your lab technician will give you a model with representing your digital wax up, meaning that the design that they have done, they will send to their 3D printer, print out the model with the wax up on top of it, and send it to your dental office or to your clinic. What you need to do next is to fabricate a silicone key, as you can see here, a silicone index on the model, which is cut in a certain way so that you do not spend much time fabricating this or putting temporary crown material in the patient's mouth. After you have fabricated on the model, on the 3D printed model, the silicone key, you then insert inside the silicone key temporary crown material. Usually we use a lighter shade, and then we put this in the patient's mouth. Now, what happens when you put this in the patient's mouth? The reflection, or what you saw on the digital wax up in the software, will be reflected on your patient's teeth. Then the next step, so what I have done is I have transferred this digital wax up to my patient's mouth directly using temporary crown material or bisacrylic material. Okay, then the next step is to present this to my patient. I present this on a screen. I show my patient a before and after. Usually I like showing videos of a before and after because it shows natural motion and the patient gets more involved. Of course, there's a way to present this to the patient because the presentation procedure that you use is very important. We want to really motivate our patients. We want our patients to really feel that this is what they have wanted all their lives. This is what they were expecting. And there's a certain way how we motivate our patients using music and using a sales process to get our patients. And we get patients that, to an extent, we present in a way and we motivate our patients in a way to an extent that we get patients that cry when they see the mock-up, patients that laugh out loud. Every patient will give you an experience that's totally different than the other. So there's a protocol that we teach how to present this to your patient and how to motivate your patient really. This is the before and after photo that we showed our patient. We also showed her a video. What's next is I'm going to show you a video of our patient, her reaction when she saw these two photos and when she saw two videos playing in front of each other or across each other of the before and after, and you will see how she reacted to the mock-up that we showed her. This is the coming video. This is the patient's reaction. And you can see that as soon as she saw the mock-up, she could not believe herself. She started laughing out loud. Look at her eyes, and you will see that her eyes became a little watery. She was very emotionally touched with what she saw. And this is where you get your patient's acceptance, and they really like what they have seen. And this is the point when you sit with your patient next and you start to explain to your patient the treatment plan. Only then can you explain to the patient your treatment plan, because you have touched your patient from the inside. You have made your patient really value what you are giving them. You have made them feel how experienced you are at this process, and you really know what you're doing. Then only can you discuss the treatment plan with your patient and start to show them the designs that you have done for this case in 3D. And believe me, when you start doing this, patients love the process and really get involved. Especially engineers, they love to see this on softwares because this is a lot like what they do in their work. So they get they really value what you want to do there. So this is a simple slide just showing the phases that the lab does for you as a plan and shows you this in 3D. This is the initial design with the lines on it, and we show the patient, of course, the photo with the lines on it, and why we explain to the patient why we used every line and why this is important, so that it looks good on the patient and it looks as a customized smile for that patient. And then we show them the mock-up and how we use natural shapes, and we have placed these teeth, or we have done the digital wax up according to these lines. And we also start to design and show the patient the treatment plan, because remember, on the right side, we said that we have our gingival margins that are a little short, so we'll need to go for some slight gingivectomies. So we have to explain this to the patient This might involve extra cost for the patient. It might involve also an extra guide that we use for the case, because everything we plan, we fabricate a guide for. And then what is very important, and a question that we're always asked by the patients, do I need to reduce the teeth, and how much do I need to reduce my teeth? And this is something that you have to all understand. When we do a mock-up, and or your lab technician does the mock-up for you, usually we bring all the teeth to the outside, meaning the case is additive. Means that all the teeth or all the wax-up is additive for this patient coming outside. Does that mean that my finals are going to be in the position? No, because you have to decide according, of course, to the lip support. Do I need to bring the teeth in, or can I stay at this position to the outside or not? So for this case, both her centrals were a little more protruded than the rest of the teeth. And you can see here that when we brought the teeth in, because the mock-up is additive always to the outside, when we brought the teeth in to our final position, to the position that gives the correct lip posture and position, and the correct position according to our, of course, our gingival margins also, we found that we will need to do a slight reduction in the centrals, in both centrals, right and left. So now we are discussing with the patient the amount of reduction that we need, because we can see this in 3D, and we are discussing this with the patient at a later stage. And this also will become a guide for us that we use, or we give our clinicians, so that they know how much to reduce beforehand. Because the lab technician has the final plan in his hands, or the final results in his hands, before you even start working for your patient. So that you can give your patient exactly what you have shown the patient in the beginning, you also as a dentist have to be controlled, not only the lab technician. So we'll control the lab technician with the smile design. We are going to control the dentist with the guides that we use for every single step. So we have a perio guide, a guide that shows you the amount of gingivectomies that you need to do. You place this guide in the patient's mouth and start to do your clinical work, and a preparation guide, a guide that shows you the amount of reduction that you need, and then guides also for the manipulation of the composite. The last step is producing devices, where we 3D print or we mill, let's say, our restorations, or we 3D print our models or guides. And this is the way that the lab, after you have discussed the treatment plan for the patient, and you have got acceptance from the patient, and the patient is going for the treatment, then your lab designs, completes the full designs, and then they manufacture the guides for you, and they manufacture the restorations for you if you need. Okay, so this is the full digital workflow. Now we go into the important part that I'm sure that a lot of you have been waiting for some time. How do we implement this whole process with the digital direct composite protocol that I have come up with? So to start any protocol or anything new that I usually think of as an idea and I want to introduce, I usually look for the most difficult cases to implement the concept on clinically, so that if it goes well with the most difficult cases, then for sure it will go well with the most simple. And this is usually the challenge. I make it more difficult on myself, but at the end, it becomes a more predictable and repeatable protocol. So I used to always look for cases with multiple spacing, because these are the most difficult cases to implement intraoral composites for. So this was our first trial. I'm going to show you the steps that we went through for the whole process and our trials, and where we went into fault and where we were succeeding, so that you can understand the protocol very well. So this case came in, we did the same protocol. We're going to go through the same protocol once more, but not in details, just a step. We started the smile design according to the patient's face. This is our digital workshop. Sorry. And again, the natural shapes that we chose. According to the smile design and digital wax-up, we then did the mock-up for the patient. We showed the patient first. We got patient acceptance. We showed the patient the slide of the before and after. And then we started to fabricate guides. Now, this is the first way of thinking that I thought of. On this 3D printed model that I have here, I started to fabricate two guides. Now, the lab did the wax-up for me, and they printed the model for me with the wax-up on top of it, okay, with the final position of the composites where they should be. I fabricated a simple silicone index palatally that we all know how to do, and we were all taught how to do when the lab does a normal wax-up for you. You usually start to build the silicone index for the palatal, and you start to build up the palatal aspect, and then you build up on your own with your own hands the labial. So the palatal guide or the palatal index just shows you your outline of of the teeth. So I decided to think in a different way. I did a palatal guide and also at the same time a labial guide. So this is the normal palatal guide that you're all understood. And usually these cases we do from the second premolar to the second premolar. So the silicone was cut until the 6th so that we have support on the 6s. And this is the normal palatal index. And we started to build up the palatal surface. And then added to that, I thought, let's do also a labial index, and so that we can copy. We do the labial index, of course, on the 3D printed model. So when we press on it with the silicone putty and light, we take an impression of the texture, and we take an impression of the embrasures, the gingival, the incisal embrasures, and the shape of the teeth from the labial, so that I would not need to adjust the shape of the tooth with my hands or with a burr. So this is the palatal index in place. And of course, we have certain limitations. If you are doing this freehand, let's say, without isolation, without using rubber dam, of course, it's much easier. You do not have any problems with the support of your guide. But when you have clamps there on the 6s or on the 7s, and you have a rubber dam placed, you can't use the palate as support for your guides. And this is very important when you come to think of any guide, even a surgical guide for implants or whatever. When we always think of what is the guide supported on, and we always look for different ways to support our guides. So here, when you have a rubber dam, you cannot use the palate anymore. The only reference you can use as a guide are the teeth that you have from the 6 to the 6 if you're clamping or you're putting your primary clamps on the 7s. And when you have designed the wax up from the 5 to the 5, the only reference you have is the 6s, the palatal aspects of the premolars and some of the palatal surfaces also of the anteriors. So here we're placing the palatal guide, we're resting on the 6s and on the palatal surfaces of the posteriors and the anteriors. We started to build up the palatal shell, and from there we also started to build up layer by layer. And here we were laying the composite also, because this is one of the things we wanted to reach, that we would not only be able to copy the shape of the digital wax up that we did and the natural shapes, we want also the ability to build up the composite layer by layer so that we give the natural 3D effect. And this would be an advantage of using this protocol than milling, of course, veneers or indirect restorations, because they're usually, it's not easy or you cannot do this in a predictable way with buildups. So here we are building up the labial surface. We then started to use the labial guide. But now if you notice, I'm pressing, when you look at the mirror, I'm pressing on my guide with my thumb or with my finger so that it's stabilized in place. So it depends on the amount of pressure that I was implementing during the process itself. So the more pressure I exerted, the less depth I would have or thickness I would have for the composite. And if I had pressed at one moment more than the other, then I would have differences in my results between the different teeth. So this was a limitation with this guide. So when we did the first central, it looked beautiful, and all we needed to do was to remove the excess material. Of course, we used stones and burrs at the time, and with our lancet, we had no problems there. And as you can see, the results that we got with the patient were very nice and very beautiful. This is the side view of the whole set of teeth that we were able to get to. But remember, at the end of the workflow, we always said that the last step that we do is quality control. So now what I needed to do was to compare my digital wax up that I did on the software with the results that I got. So now look at the photo on top, look at the central here, and look at the central at the design. It looks perfectly the same. But now look at the lateral on top here that we got clinically, and look at the digital wax up here. The lateral here on top clinically is a little rotated. Yes, we got the same shape, but it's rotated, it's deflected in position. The canine also, and the 4s and the 5s have followed. So this is where we got the problem. The centrals, we were able to adjust 100%. But the further we got posteriorly, because we build up tooth by tooth, the guide would not be in place, or the stability of the guide would not be 100%. So we were not able to give the exact same result as the digital wax up that we had designed for the case. Now, if you do not use quality control, of course, then you would love the results that you saw on the first slide, and you would say, oh, wow, this protocol is lovely. But this is not the predictability that we want to reach. We want to reach at least about 95% of a copy of what we had started with. So we started also, when we were comparing the left side, we found also that we started to get a shift in the midline. We started to get a slight cant. The central is a little thicker than the other buccolingually. So we started to see other defects also. So then we brought in a second case, also a multiple spacing case. We did the same protocol. We did the smile design first. We did the digital wax up, but we started to use the guides in different ways once more. So we used a palatal guide first, and we used a labial guide. It's the same as the first protocol, but here, if you look at the thickness of the guide, the thickness of the guide is much, much thicker. The labial guide is also cut in a way that we do not have a lot of excess material, because in the first case we had a lot of excess material gingivally that we had to finish. So we cut the silicone index in a certain way so that when we place this guide in place, the excess composite would be easily removed with a probe before curing, and we would not need to do a lot of gingival adjustments. Also, we started to open for ourselves windows, meaning that this guide was resting on all the patient's teeth with the palatal aspect also, because the first guide would only rest on the labial and the palatal guide would rest on the palatal. But here we started to take support from the palatal aspect, and we would open a window for, let's say we're doing the two centrals labially, we would open a window from the backside so that we can implement the composite and press the guide in place, and it would still rest on the palatal surfaces of the rest of the teeth while it is in place. So this is a way that we thought of to get better support for the silicone index, and the same for the palatal guide. We would, every tooth we would start to do, we would open a new window for it so that we would not lose the support as much as possible. So from there also, we finished the whole case from the second premolar to the second premolar, and then we started to compare again the digital wax up with the final result we got. Now look at the texture we have on the digital wax up here, and look at the texture we were able, the natural texture that we were able to give the patient. And the best thing about this process is I tested it on myself, because I'm not an expert with composites actually. And to me, this is a protocol that I wanted to find that would be easier for any general dentist. So if it was good in my hands, it would be good in any general dentist's hands. You can see after the polishing process, this notch in the lateral that we were able to mimic here, the natural texture on the central that we were able to mimic here, the shape of the central itself, how we were able to mimic. We got very nice results, but again, we did not get the perfect results that we wanted. Again, we had instability of the guide itself. It was better than the first case, but still it wasn't the perfect results that we had wished for. So I was not very pleased with the results. So I went to trial number 3. And again, a multiple spacing case again, so that it is even more and more difficult every time. And if we have success with this type of case, we will be able to succeed with the rest. So this was trial number 3. And this is where we started to really get good results. We did the smile design again according to the face. We did the digital wax up, and we did the mock-up for the patient first. This is only the mock-up. We showed the mock-up to the patient, and then we started to fabricate guides in totally different ways. We started to fabricate silicone guides or clear silicone guides. We did not use additional silicone in the step. We started to use clear silicone guides, and we started to use a pressure pot, so that we can adjust or compress the clear silicone in the guide itself, so that we do not have any air bubbles. We started using a vacuum form stent over the clear silicone, and as you can see, we started to divide the process of implementing the composites into 2 stages, meaning we divided it into anterior and posterior. Now you can see here that I have fabricated vacuum form stent, and inside this vacuum form stent I have injected clear silicone, and I have adapted this to the model in a pressure pot, and we have only placed the clear silicone from canine to canine, so that we build up the canines first, and we have total support on the 4s and the 5s, and then later on we would then do the 4s and the 5s. And of course, we had 2 different models here. The wax up was done from the canine to the canine in the first model. And on the second model, we have the total wax up from premolar to premolar. So now we are sure that the stability of the index or the guide that we're using is much, much better. The same process for the palatal guide also. So we use the palatal guide and 2 labial guides, also 1 anterior, 1 posterior on 2 models, on the same 2 models that we used from the beginning. And this is the posterior guide for only the canines and the premolars. So in the anteriors, we did from lateral to lateral. And then on the posteriors, I'm sorry, we did from canine to the second premolar. We did the normal protocol that we all use for any composite. We isolated, of course, using a rubber dam and the etching, bonding, and preparation process for the teeth. Then we placed in our palatal guide from lateral to lateral. And then on that, we started to use our labial guide from lateral to lateral. We finished from lateral to lateral, and then we went from canine to premolars. And here we just the flashes of the extra composite or excess composite was just removed. And you can see here, this is an important step that we adjusted the silicone index. Also, we started to adjust it so that we do not have any extra flashes of composite. This is before the polishing process. Here we have the results after we polished and we glazed. This is the frontal view of the patient, and this is the final result that we were able to give our patient. Notice that we have adjusted all parameters. Of course, these photos would look very beautiful for any case that you show of a before and after, but what's most important for us, again, is quality control. Here, we did not build up, actually. We just used 1 shade for the case because we wanted to actually get the protocol right. And if you got the protocol right, then you can just build up as you like. It's the same process. And again, the before and after of the patient, the smile before and after. But what's most important is the quality control here. Now look at the printed model here. This is a side view of the printed model. And this is the side view of the patient's mouth of the finals. And you can see like a fingerprint here on the printed model. And we were able to copy exactly these shapes and this texture that was on the printed model to the patient's final restorations. And this fingerprint is usually a defect in the 3D printing. And unfortunately, I did not notice that until I finished the case. But I was happy that this was there because it showed the amount or how we were able to copy how much detail from this printed model, even those simple fingerprints, we were able to copy to the patient's final restoration. So this was the side view. And then when you also compare the frontal view, you can see that the amount of deviation that we have between the printed model and the final restorations is actually minimal. And we were able to copy the shapes, we were able to copy the texture, we were able to copy the gingival embrasures, also the incisal embrasures, the shapes and the texture. So it was a 1-visit case. We were able to finish very quickly in about from the beginning of the process, from the isolation to the finalization. It took 2 hours, and then we just bought the patient after a week just to finish and polish and to glaze. And then we took our photos. So it was a simple process. Of course, we did from the second premolar to second premolar because we're changing the patient's full smile. And again, a smile photo and a retracted photo. And again, the side photo showing the texture and how we were able to copy the results, and the patient pre-op mock-up and the finals showing the same results every time for the patient. But we did not stop there. We were still determined to get even more accurate results. And we started to think of doing guides in different ways, digitally designing guides, because the guides we used in case 3 were manually made. Yes, the printed model was digitally designed and manufactured, but the guides itself for with using the clear silicone was manually made. So we started to think of a way to digitally design the guides and to 3D print the guides so that they're even more and more accurate. So we bought in this last case, the case that we discussed, that we did the smile design. We started to think of totally different ways of how to stabilize our guides. Here we did 2 actually wax ups. They are the same design. This is the full wax up, but if you notice on model 1 that we removed 1 tooth, or we have 1 tooth on, 1 tooth off, meaning 1 wax up there, 1 without, 1 with, 1 without, 1 with, 1 without, and so on. And the whole point was to fabricate a guide where we do 1 tooth and the other not, so that the guide would stabilize on the tooth that you have not touched and stayed the same. And we fabricated 2 labial guides and 2 palatal guides. One palatal guide for the model that was with and without, one with, one without, and then a same labial guide for one with, one without, and this is digitally designed guides. And we also added support to these guides in the palatal surface so that we do not have any flexing of the guides themselves. And then we started designing also 2 other guides, one for the palatal and one for the labial. I'm sorry, this photo should be of the model with the full wax up, not without the wax up. So we actually in the protocol we did 1 tooth yes, 1 no, 1 yes, 1 no, 1 yes, 1 no, and then the other 2 labial and palatal guides we would do the teeth that are remaining, so that we had support of the guide. And of course the second guide, because you already have composites that are done 1 tooth on, 1 off, you need verification windows that show you that the guide is placed and stable in place, so that you would make sure that you would get the perfect results. Unfortunately, I did not complete the case. This was before we stayed at home, so we were able to start to test the protocol itself. We did not fully, we finished the case, yes, but we did not take the final photos, I'm sorry, for the case. So this is the palatal guide in place with 1 tooth on, 1 off, and isolation with Teflon tape. And then this is the palatal aspect. We built up the tooth, and then we use the labial guide. And you can see this is fresh after we removed the labial guide. You can see we just have flashes of extra composite here that can very easily be removed with a blade. And you can see the amount of texture and the buildup and the natural look of the central that we are able to get. And this is a close-up view of the central without removing the extra flashes that we have. And you can see that we have the line angles there mimicked. We have the texture, we have the incisal edges, the whole shape of the central. And this is a side view also of the central that we are able to get. And I hope that soon after we are back, we can take the full photos for the case, and we can show you how these guides were even more successful than case or trial number 3, and how we were able to get to a predictable and successful protocol for these types of cases. At the end, I'd like to thank you all very much for your attention. I'm sorry if I had taken too much of your time. This is just like a simple slide. If you would like to contact me at any time, this is my Facebook and my Instagram. Please take a photo of the slide if you would wish. And if you have any other questions regarding the cases or the protocol that we're using, please feel free to ask at any time. Unfortunately, we cannot. This is a process that needs some time for you to understand and to practice and to be able to implement. And we would need even 3 or 4 more hours more to discuss this with you so that you can understand the protocol itself. But if you have any questions, I would be glad to answer them. And at the end, also, as a take-home message, as I said, I am a board member of Digital Dentistry Society, and also the president of Digital Dentistry Society Arab Union, meaning all the Arab countries. And Digital Dentistry Society actually is a society, an international worldwide society that is a reference to digital education and publications, because when you have any new way of thinking in dentistry, which is digital dentistry and is the future of dentistry, actually, you always need a society that can be a reference that you go back to if you want really evidence-based knowledge and education and the right type of education regarding digital dentistry. So if you would like, please take a snapshot of the slide, and you can scan this barcode. And when you scan this barcode, you will be redirected to the Digital Dentistry Society website. And from there, you can choose to become a free member, where you only need to register your name and email, and you have access to educational content there and a lot of benefits. And you can go then also to the active membership, where you have to pay an annual fee, and you get more access to our whole educational online platform on a yearly and annual basis, if you would like to understand more about digital dentistry. And this is the end of the lecture. And Sarah, are you still there, or did you sleep?
Yes, doctor.
Okay, perfect. So my phone is dead, and so I can't see the comments on my timeline. that I have shared. But if you have any questions, I would be glad to answer them. So if you can read out the questions, that would be great.
Yes, and I have a few questions on my behalf.
Okay, so I'm going to stop sharing and yes, so that everyone can see me there. How to detect whether the cant is skeletal, dental, or muscular discrepancy, and how to fix it reasonably to prevent relapse if it
after DSD job
the DSD job accomplishment. Well, of course, to reach a full diagnosis if this is skeletal or dental or muscular, you can detect this through the face itself and see where your main problem is. You can bring in the CBCT also and see the skeletal discrepancy if it is there or not. But usually, if we're thinking of adjusting a cant that is, let's say, in a prosthetically, there's a limit, of course, because you usually have biological and functional limits, usually mostly biological limits if you want to do this restoratively. If you want to do this orthodontically, of course, it is an easier and more conservative process. So, of course, there is a lot of ways. Yes, of course, you have to detect the reason for the problem first. So you can reach this diagnosis when you, and this is the beauty of digital technology, when you register the face to the model, to the CBCT, and all in one space. So you can see the relationship of if this is a muscular or facial discrepancy, or if this is a dental discrepancy, or if this is a skeletal discrepancy. You reach your full diagnosis first, and then you will be able to treat the problem according to its reason from the beginning.
Okay, another question we have is how to determine the ideal position of teeth buccolingually.
The ideal position of the teeth buccolingually. That's a very nice question, actually. Two things. Usually the lip position and lip support. That's number one. Number two, also, I'm usually asked this question, when you bring the teeth in from the mock-up, how far do you go in and where do you know where to stop? Well, we place the new set of teeth in the natural position that God has created teeth and gingiva. Now, the gingiva is usually superior to the teeth, right? So we bring the teeth in till it is inferior in position buccolingually to the gingiva, and then we stop. And when we adjust on the occlusal view also, we adjust our occlusal curve, okay, so that we have an equal occlusal curve on both sides. So that's our limit to bringing in the teeth buccolingually.
Okay, another question is why do we use the rubber dam if it's affecting the accuracy of the guide?
Well, number one, you need the rubber dam for isolation, and you cannot place direct composites in a patient's mouth without isolation. Otherwise, they will not live long. This is a protocol that you have to use when you're going for direct composite. And this is an important point also. Please put in mind that the composite that we're using for these types of cases are packable composites. This is not flowable composite. So yes, you can use the same protocol or the guides, and there are similar guides, of course, for the flowable injection technique. And in this technique, they do not use a rubber dam. Why? Because flowable composite at the end is a temporary restoration. It's not a permanent restoration. So this is not a restoration that can withstand occlusal forces for a long time. So if you're using the flowable injection technique, meaning using flowable composite to restore a case with composites for a certain period of time, which we call a transitional phase, if you're going to increase vertical dimension, let's say, and you want to stabilize this patient for some time, yes, you can use flowable composite without a rubber dam. But if you're going to use permanent restorations for this patient, then you use packable composite, and then you need to place a rubber dam. So this is one of the differences that people misunderstand. This is not flowable injection technique. This is not using flowable composite. This is a little more difficult and a little harder in implementation because this is using packable composite as a permanent restoration for the patient that should live a mean lifetime of at least 5 to 8 years.
Okay, I have a question, my own. Are there any cases that are contraindicated for this technique, sorry?
Contraindicated, the contraindication would be any, like any restorative case. that you have not stabilized this case before, meaning you have the patient is not in good periodontal health, you have not you have gingival bleeding or periodontal problems, you have active caries, you have all active disease, meaning. So you need to stabilize the case first, and then of course it would be indicated to go for this type of case. Of course, patients with let's say a deep bite or edge-to-edge occlusion, it would be a little risky, but it wouldn't be contraindicated. We're seeing a lot of cases with deep bites that you use packable composites for, and they live long enough. Of course, they will not live as long as, or they will be at more risk of fracture than ceramics. But if you have adjusted your occlusion well and you were able to detect the defects or the problems that you have in occlusion, you will not have problems later on. So occlusion, as I described before in a past lecture, is usually the biggest reason for our failures in our clinics after some time, and these are the patients that usually haunt us. So this is something that we cannot run away from any longer. We have to really understand occlusion well. We have to understand how to adjust patients' occlusion and how to make, and this is what's going to actually be the borderline of is this restoration either ceramics or composites? Is it going to live long enough or not?
Okay, a question we just got: if we will use injectable composite, which is the best site to make holes for excess resin to escape?
What I've seen is that the holes are made with a diamond stone, and you do it on the labial surface. And the most important is that actually it's not a place for the flowable composite to escape from. It's a place where you can place the tip of the flowable composite from the incisal, and you keep filling in so that you make sure that the flowable composite fills in the whole space, and the excess material will stay there. But you are able to remove the excess material with a lancet very easily, because you isolate the neighboring teeth with Teflon. And you do not have any, and you have not placed any etchant or bonding agent on the adjacent teeth. You've isolated from the beginning during your process. So any excess material is easily removed with a lancet, and later on with a stone if you want to really fine adjust. So the excess will actually stay there. The hole is not for the escape of the excess. It is for placing the tip of the flowable composite, and you have the index itself usually exerting a lot of pressure. The clear silicone is usually exerting shaped on according to the shape of the tooth, and exerts a lot of pressure on the teeth. So you will not have a lot of escape of excess material unless you really inject very hard and you keep injecting more than you need to.
So does the final restoration accept any kind of readjustment or finishing?
Which with the packable composite or the flowable?
No, the packable.
Yes, of course. But the adjustments are only the excess material that you have, and you can easily, as I said, remove this with a lancet. If it is too hard, then you can just adjust this with a burr, but this is usually gingival, just excess material gingival. Otherwise, the whole labial surface and the incisal and the palatal surface that you have built up is untouched. That's the whole point of the protocol, that you are able to copy exactly what you have on the model in a predictable and repeatable way, so that you do not need to play with your or touch it with your handpiece. So no, all these cases, there were no adjustment with the handpiece except for the excess flashes if we needed to, which are usually removed with lancet easily. If it's too hard, we just adjust it with a stone, and this is usually the excess flashes. But the labial, the incisal, the mesial, the embrasures, everything is already duplicated from the 3D printed model. That's the whole point of the concept, to duplicate what you have as a design in the patient's mouth without any adjustments. And this is actually the protocol that we depend on even in our ceramics with our labs. What comes out of the milling machine is untouched. Why? Because we are using natural shapes. We do not want to remove this natural texture that we have on the labial surface. All we do is finish, polish, that's it, and very carefully so that we do not lose the texture.
Okay, I hope we've answered all the questions. Thank you a lot, Dr. Mahmoud, for your time. Thank you for making best use of our free time currently. Thank you so much.
Thank you, Sarah, and thank you all for your time, and see you all soon. Thank you very much. Bye-bye.
Goodbye.